whenever.
We're good? Okay, perfect. Sounds good. So I'll pull a few additional things up, but this is, sorry guys.
No, you're fine.
You're fine.
This is the MRI from today. I don't have the one up from before, but I think you're gonna see that this is new in this area. And then probably the more pronounced one, oops, if I go in the right direction. So this area is new. That spot is, wherever that was, that's stable. That's always in the same spot that we've been following.
Okay.
This is the resection cavity. That area is stable right here, but you're going to see as we go up here into the parietal lobe, this is new in this area. Now, and I'll scroll all the way up so that you can see it. So it's really those two new areas. This one, stable, and this one right here. Now, when I look at the perfusion and trying to do the overlay, for example, I'll blow this up so that it's easier to see. I admittedly have a little concern about this one because I see a bit of perfusion, but it's not red hot. There are a few areas that light up a bit more, but this is vasculature that runs adjacent to that. So you can artificially get a little bit of a picture. But on top of that, here's the thing that becomes challenging. If you look on the contralateral side where that normal vasculature, you can see it runs in a bit of a ring right here, and you see a bit of a ring right here. So this one I admittedly worry about a little bit more than the other one that I'm going to show you in a second. But again, it's not
because of all the white that's showing.
The white worries me here, but the question is the white necrosis and just treatment change, or is it perfusion? And then just to reiterate, perfusion, blood flow, signifies viability. So we know, for example, that if we go to an area like this, blood vessels here, lots of viability and within this region, and the same can be true for certain tumor spots. Now I see, what I want to see is an absence of anything in this area. I'd rather it just be completely white without any overlay of perfusion or blood flow. And what you see here is there's a little bit in that area. You can see that ring, but again, we see something on the contralateral side, and so how to interpret that in the context of something that looks somewhat similar on the other side is difficult. These little tiny spots in here do give me a little bit of pause, meaning the where you see it almost turns yellowish in those areas does give me a little bit of pause. This red spot up here, that's vasculature. You can see it on the other side. That's clearly a large vessel. But here, for example, here's another slice. There's essentially no perfusion in that area whatsoever.
Okay.
As we get up a little bit higher here, as we go up to this area, this one's tricky because it's right next to all of these blood vessels that are right here. But again, a lot of this doesn't have any meaningful perfusion, and the areas that do are adjacent to where we know these blood vessels run in and stick out on the gyri on either side and sulci here. And so there's maybe a little elevation here or there, but in general, I'm just pretty unimpressed.
And that's new compared to where the tumor that was removed.
Correct.
So where was the tumor that was removed?
The tumor that was removed was going to be this is just fibrotic tissue right here, but that's this area where that tumor was removed here. That has all kind of collapsed on itself.
Okay.
So it's adjacent to it, but it's a little bit separate from where it was. But you can look and you can see that this is clearly a blood vessel. And in fact, let me go back and go to the perfusion on the last MRI wasn't good, but let's go back to June and put these side by side. In fact, let me put this up here and let me put this perfusion up here, and then we'll blow this up so that it's easier to see. So when I look at these areas, I say, oh my goodness, you can look at this and say, oh my goodness, there's a bunch of red that's within the white there. But if we look, even at the prior MRIs where we don't see those spots, that's just these vessels right here that are reaching out and overlapping where that area is. So again, you have to interpret that with caution. So really the area that's rip-roaring and red here are just normal structures. The white itself is not particularly high.
But the white is what would be a new growth of some sort.
Of some sort. So it could be, the question is it breakdown of tissue, meaning necrosis, late radiation necrosis? Again, I know it's a year out, but it can happen.
Oh, yeah.
It tends to happen earlier, certainly within the first 3 to 6 months, but can it happen later? Yes. The other thing too is usually when we see progression, not always, but usually when we see progression, I expect to see a spot of progression. It's kind of unusual that these two spots are simultaneously developing at once. And so again, it's a little bit of a mixed picture. I could fully see people looking at this and calling it progression, if I'm being honest with you, because of the timing, maybe because of some of the other features, particularly in this one. But again, it's not the most convincing story, and this is why I need to be talked into it one way or the other. And so I need a neuroradiologist and a neurosurgical group and everybody else to look at this all at the same time to come to a consensus on this. I think the question then becomes, depending, if there's still, so two things. Number one, maybe they'll have a more definitive answer. I think at the end of the day, we're going to be running on some degree of uncertainty. I do think that the extent of change is enough that we have to make some sort of adjustment moving forward. And the question then becomes, if we're still not sure, is this something where if they offered you a resection of that area to take it out, that you'd be, or a biopsy, that you'd be open to doing that? And that's not an answer that I need right now.
Right.
I think that's something to think about, which can give us an answer in so many ways. I think then the question becomes, if it is tumor and we're worried about that, well, let's look at it both ways. If it's necrosis, what do we do in a case like this? Well, one thing that we can do is blast it with steroids, your most favorite thing in the world with all of this. I think while you're feeling generally okay right now, I don't know that we need to go into that, and I don't know that steroids for you, and I mean that respectfully, is the right option. There is, and I guess I didn't show it to you, but let me pull it up here. This is the flare. I'm sorry, you can turn your camera back on if it's not. The flare to look at swelling and other things like that. So there might be a little swelling around this guy right here. And as we get up a little bit further in this guy, you can see there's more swelling that's happening in this area. Now, there isn't a great degree of mass effect. The thing that always, when I look at this and I say, okay, there might be swelling and change, it's not really generating a ton of mass effect on the ventricle itself, which is reassuring. But regardless, there is some degree of swelling, and it is going to become a problem if we don't ultimately do something about it. So I think a couple of options. One of them would be, so let's pretend it's necrosis for a second. One of them would be a watch and wait approach to see how it goes. Obviously, steroids are an option, but Avastin is another option in that setting. Avastin works really well for necrosis and swelling. The caveat for Avastin,
It takes you out of trials.
It takes you out of trials. But admittedly, if the necrosis propagates, causes issues, and knocks down performance status, then A, your quality of life is ruined, and B, you were never going to be eligible for that trial anyways. So you kind of hold out, and I mean this is a general you hold out hope for something that wasn't going to happen, and so in some ways you can shoot yourself in the foot with that. But obviously you need to make sure that what you're doing is done with the right interpretation to begin with. So Avastin, I think, would be Avastin versus surveillance are the two options if it's necrosis at this point. I would worry that in the absence of doing anything, that this is just going to continue to propagate if it's necrosis. If it's tumor, then the question becomes, what can or should we do about it? So Avastin always remains an option in the background if it is tumor, but it's not the end-all be-all in terms of survival benefit. It helps with swelling, it helps with other things. There is, so surgery, of course, as I talked about, is a potential option in that setting. We do have a clinical trial with the implantable ultrasound device. Now, the issue with that trial is that the tumor needs to be relatively confined to a singular area. And right now, we're dealing with presumably two separate areas, and it needs to be no bigger than 5 centimeters, which we're right now. So if we're calling this tumor, that trial is somewhat off the table with things. There is a trial, the GBM Agile trial that exists right now. It would necessitate the next step be lomustine, CCNU chemotherapy. And then there is a control arm where somebody just gets, nobody gets nothing, but they just get the CCNU option. And to that, there can be several agents that are added on, a drug called VT1021, which directly it induces something called thrombospondin. It directly targets the vasculature and the tumor itself, but it also disrupts the suppressive component of the immune microenvironment, so it can, in theory, induce an improved immune response against the tumor. There's an arm that looks at a drug called I just mentioned tririzolol, which is a glutamate signaling inhibitor, which is often overactivated within the tumor. There is an arm called ADI-PEG20, which is essentially an asparaginase enzyme. It basically breaks down, or arginase, excuse me, breaks down arginine, so an amino acid that the tumor needs in order to survive. Those are all added to the standard of care lomustine in this particular case. So we can cross that bridge when we get to it and talk about it a little bit more. But I think I have a spot that's available in that trial right now here. But we'd cross that bridge when we get to it. That trial necessitates that we're not on a certain level of dexamethasone or going up on it. Right now we're good, it seems like, from that perspective.
I'm not even taking the hydrocortisone.
So then we're definitely good right now.
Yeah. I took it a couple days when I started having the pain, thinking maybe a little bit will help if I'm having swelling. I don't know if the hydrocortisone does or not. But, I mean,
probably didn't hurt.
Yeah.
Didn't hurt. In terms of other things, if this were tumor, so we're far enough out that reirradiation is an option. We're far enough out that we could do more temozolomide. I don't know that would be the option that I would go with right now. Obviously, your favorite thing, the appt device, is always an option. I just throw that out there as a standard of care. But the lomustine is an option independent of clinical trial or not. If you were taking a standard of care approach, it could combine those things. So it could mean temozolomide concurrent with reirradiation to these areas, followed by either more temozolomide or switching to lomustine at that point. So doing that reirradiation. All of this can be plus or minus the Avastin medication, but I think we kind of just need to sort things out first with this. Obviously, we have the I think the Agile trial at the moment is the one that you would qualify for that we have here. There are obviously other sites that have trials too, and I think that would then, depending on what you want to do and what you're looking for, that would be another option for you too.
Okay.
But if you'll humor me, let me present it at the tumor board tomorrow and get back to you on this, because I really want to make sure that we have a consensus with this. Most of the time it's always you, Tiana. You make it challenging, right? I love it.
Nothing's easy.
Yeah, most of the time I could look at these MRIs, the vast majority of the time I could look and I could say this is tumor or this is not tumor. And it's never usually that easy, but usually I can
You just have a
look
gut
at it.
feeling usually one way or the other.
Yeah, and this one I don't have a clear gut feeling, and the other part of it is I am biased. We're all a little bit biased right now, and so part of my bias is not wanting it to be progression, but I also want to make sure that's always my bias, but it's particularly my bias for you. So I want to make sure that somebody with maybe a little bit more of an objective stake in the game says it, because the truth is, if it is tumor progression, that sucks, but we need to manage it that way. And I can't bury my head in the sand and say it's necrosis at that point. So
I'm sure, I don't know what you guys discussed. I've never gone to tumor boards, but I mean, if they look at it and say, it is necrosis or it is like tumor, obviously they would recommend next steps. But I guess my question is, what would I notice anything if it was one over the other? Do you think as it progressed?
So it's a good
either way.
Yeah, it's a great question. So in theory, you could have side effects from both of them. Having said that, the more profound side, there's actually data about this. Pseudo progression or the necrosis tends to manifest with less symptoms than if it truly is disease progression. So you even though you had the pressure, what I'm talking about is like true neurologic symptoms where things are not as good, they're more constant, all of that. So your symptoms argue more in favor of treatment change driving this, or maybe I should say the lack thereof of symptoms argues more in favor of that. But anything can happen with either of them.
Okay, makes sense.
Just keep notes of things.
Yeah.